I have been a consultant in Causeway Hospital Emergency Department since 2006. I've been a doctor for 23 years, with 20 of them working in emergency medicine. Since taking up my post in 2006, yearly attendances in Causeway Emergency Department have increased by 25%. The local population around here can double in the summer months, and the nearest other emergency department is 1 hour away. The department now sees 45,000 patients in a space that is designed to see 25,000. When I started in Causeway Hospital, trolley waits were relatively rare compared to the departments in which I had trained. Now they are the norm. Trolley waits have been with us for a long time and were first recognised as an issue in the mid-1990s. These are patients that have been seen, treated and diagnosed with a condition requiring a hospital bed but must remain in the emergency department due to lack of available beds in the wards. In no other area of the hospital would such a situation be deemed acceptable. The staff of the emergency department simply has to cope. Coping comes at a cost to our ability to carry on with our core function of seeing and treating those with acute medical need in a timely manner. Mm-hmm. There was massive investment in infrastructure and staff in England in the early 2000s. This was not matched in this region, despite a similar pattern of rising attendances and demand. We were then given exactly the same targets to achieve as England, and not surprisingly, we have struggled to from the start. The 4 and 12-hour targets are a crude measure of performance and have no demonstrable benefit to the patient. They make no measure of any quality of the care received. I had a role as a regional chair of the College of Emergency Medicine in Northern Ireland for 3 years. The college has produced a dashboard of quality indicators as well as tools and position statements regarding demand management in the emergency department. These and other processes have helped us measure and audit our performance. They have helped us to develop systems to try and keep our patients safe. When the specialty was known as the Accident and Emergency, the A&E, it was said to stand for Always and Everything. Now it has changed to the Emergency Department, the ED, and it seems to stand for Everyone's Default. This is particularly true of 2/3 of the week that fall out of hours from 9 to 5, Monday to Friday. It's been identified clearly why demand is rising. Many better ways have been devised that mean patients could access care in a timely and appropriate fashion. The lack of other entry points to care can lead to the wrong patient in the wrong place at the wrong time. They are then managed in an environment singularly unsuited to meet any of their basic needs, that is, on a trolley at the back of an emergency department. Lack of access to the hospital, but more importantly back into the community, leads to the situation we face on a daily basis. Preference for care, as in our shopping habits, has changed from a time of need to a time that suits best. Out of hours, the only shop still open is the emergency department, and uniquely we cannot control our workload. I'm proud to work in Causeway Hospital. I work in a team that has the patient's needs at the front and centre of everything we do. We have managed to avoid having a patient stay in the emergency department for more than 12 hours for over a year, and this is a testament to the hard work with the whole hospital and community teams. But this gets more difficult with each passing week. Unscheduled care remains the poor relation to scheduled care. It is simpler to look at the headlines about waiting times and try to understand the complexity of the systems which will be required to get this right. Until this changes, we will continue to cope. We will try to make difficult and complex decisions for our patients in a timely manner, often with little or no information. We will try to involve the patient and their family in this process and to do our best for our patients. We are stretched nearly to breaking point, and until this changes and the people have well thought out and funded alternatives, then the emergency department will continue to be the first port of call when trouble calls.
Okay, thank you. And within time, which is great, thank you very much. I wonder if I could start by asking probably you, Fergal, a couple of questions on the statement. And this is an issue that's come up before in terms of the 4-hour and the 12-hour targets being a relatively crude measure of quality. And I wonder if you'd say a bit more about what other measures are deployed within the trust, or what other things you think should be deployed in terms of measuring quality. What would a genuine, if you like, measurements of quality look like? What are the things that actually you think would be a better or an augmented measure of quality?
If you're looking at in terms of quality of the patient experience, There are things that College of Emergency Medicine have identified. There's a dashboard which we do look at in the department. It looks at things like people who left before being seen, unscheduled reattenders, time to hand over from an ambulance, time to seen in triage, time to seen by a senior decision maker who can decide what, if you need admitted or discharged from hospital. And these, I think, there are other things, Patricia, as well. There are other indicators that we use in the department, but from a medical point of view, I think these are much more useful in terms of looking at the patient experience than actually just a crude 3 hours and 59 minutes cut-off point.
And Patricia, what would be the kind of, on the nursing side, the what I'll call the meaningful kind of measures that?
Well, measures, we would be recording our data from our news, from our observations that they've been done appropriate. The appropriate fluids have been that some of our pathways, from sepsis pathways, neutropenic sepsis. That those types of measurements are being recorded. Our infection control data, those have been recorded and are sent centrally so that they can be formalised. Those are our safety networks, that patients are getting their observations, they're getting their fluids, they're getting their pain relief. When things become difficult, you have those to rely on when you're carrying out your care, and those then are monitored.
And I suppose my second question on the kind of if we were to look at kind of those quality measures in the round beyond the 4 and the 12 hours, is your sense that things are getting better, things are as they were, or things are deteriorating? Have you any sense of whether, if you looked at the other measures, if you like, of quality, where we are in terms of if we look beyond 4 and 12-hour time targets?
I think, we, in talking about in terms of Causeway, we have some difficulty in terms of our staffing. We have other issues around the way we can provide care. I don't think our quality has deteriorated. I think we continue to try, as I said in my statement, to provide the best care we possibly can. I think things are very difficult, things are very stretched, but we continue to try and provide the best quality we can.
Could I maybe just come in? We do have a number of indicators and ways of knowing what our quality of service is, and I would concur with Fergal. Everyone works very hard to maintain a quality service and also to measure our complaints and particularly our compliments. We monitor those, we look at those, we share them within the department, and that's part of the learning that would happen within the department to events. You are aware of 10,000 Voices, and I'm not go into the detail of that again, but that has given us some very rich information about the patient experience and how the patient perceives the experience they've had, because that's equally as important, that the patient perceives that they've had a good experience as our confidence that they have. So we use those other quality indicators as well. Patricia's mentioned about audits in relation to measuring of observations, measuring of response to pain, and those are done on a regular basis and evaluated. And again, that information is fed back to the staff. The results of those audits are up in the department, so it's a sharing with the patients as well, that those elements that we measure as safety measures, that they can see how we're doing with those.
Okay, and I think my second set of questions are really around then we're aware that obviously there've been across the trust some work done in terms of improvements, and again I suppose I'm asking for both you and Patricia, who are the a daily basis in Causeway. Would you just take us through what has been done, what are the kind of improvements that have been happening, and what's working, what isn't, or what could still needs to be looked at? And I suppose I'm particularly interested in having heard the evidence about the staffing numbers and the issue, the sense in which we've heard evidence this afternoon of people being run off their feet because of, particularly in Causeway, because of the number, the small numbers of people there. What, if anything, is around the kind of staffing, recruitment and retention issues? But do you want to just take us through the kind of reforms and your sense of what is working and what isn't, and then kind of perhaps talk to us about the recruitment, retention, staffing issues, challenges that are faced by, and I'll maybe come to you first, Patricia, and then come to you, Fergal, and then come to you, Linda, at the end.
Up until recently, our staffing had actually been quite stable with the staff on the ground, but over the last couple of years, we had developed an unstable workforce in the fact that nobody could give us a guarantee that we were going to exist anymore. So a lot of nurses looked at other avenues and other areas of nursing that they could develop, and did so very successfully, and they have reaped the rewards of that in the last 2 to 3 months, where I've lost 5 staff. And while staff only have to give a month's notice, it takes 3-4 months, for the recruitment process, and that makes it extremely difficult if you are working short. Really, I suppose from the staffing, space has always been a problem for ourselves, so it's getting certain groups, we have more difficulties. Well, not have more difficulties, but it's more difficult in the department. We would have quite a large number of children attend. I suppose that we're still talking about the 20 to 25%. To try and make that better, we have carried out children's visits for school children. The aim of that, we have done that even from the old hospital, was to alleviate fear and to make the world look not just as such a scary place, and that we're not doing things to them that they don't necessarily have ever clapped eyes on before. So that works quite successfully. And I mean, we had a visit of P2 children there yesterday, isn't it? Another group that we would work quite closely with are, because we have a house quite close to us, where patients are people with learning difficulties, and we did some work, quite extensive work, a couple of years ago based on a complaint, where we've actually worked with learning disability groups. We've taken photographs, we've used our Macathon boards, because not everybody that comes has speech. We've done some work with staff, because sometimes they're scared of some of their patients and don't know how to communicate properly. So we would have that can be quite a success, and some of the patients have come back to us and said, you saw me another time, so they actually recognise the nurses, and I think that's actually quite nice when they've seen the nurses. I suppose success is patients with dementia. We have the Butterfly Scheme, which is a regional scheme, it's a national scheme, and those patients can be identified in a very kind manner with a butterfly, so that the doctors and the nurses are aware that maybe the answers that those patients give will not necessarily be the appropriate answers, to try and keep them in an area without moving them, because, as I said, space is an issue and people do get moved an awful lot. So it's trying to keep them in one area. We would have signs at the top of the department that we would utilise for patients that have dietary requirements or need care with their personal hygiene, so that the staff aren't always going and having to ask them, can you move about, can you get around? So we have visual tools in the department. I'm thinking from the groups that really we have. The deaf community, I think we have done some work recently with the deaf community, and we're sort of looking at an iPad and with one of the voice recognition, because not everybody signs, and we don't always have people that can sign. So we're looking at developing that for some of our more vulnerable groups. I'm trying to think anything else. We have something that we have had to develop because patients are not moving through as quickly as we would like. We have had to actually get somebody to go out to the waiting room sort of on an hourly basis and check the patients. We have nurses that have advanced skills in making sure that patients do have oral painkillers. Now, we can't do anything at the moment with the IV analgesia, but certainly that they have adequate oral medication, that we can order x-rays for certain limbs, for below elbow and below knee. All those things are to try and speed up a patient's journey. The nurses will take the bloods and will, to try and process the patient to be ready for the doctor, utilising other staff, AHPs, healthcare assistants in that patient care. And in relation to our pain, we're actually going to start a pilot. And I suppose it was based on the College of Emergency Medicine, where patients with fractured neck of femurs or query fractured neck of femurs, certain nurses would be able to give them some IV analgesia and send them to X-ray, so to speed up their journey through the department, albeit we don't have orthopaedic services on site, and do then have to rely on transport to get patients to Altnagelvin would be our orthopaedic site, and that is probably one of our problems is getting our patients out to different areas or out to the ward.
Okay, thank you. Fergal, again, the same to you. Kind of tell us about the sort of reforms that have been implemented, and the ones that you think are working, and the ones that are still posing you challenges.
I think one of the biggest challenges, well, in terms of reforms that are working, I think Patricia's covered a few of them there. I think are very important. Are empowering our triage nurses to order X-rays has really speeded up the patient journey. I think training our nurses to give intravenous analgesia and order X-rays, again, of people with possible fractured necks of femurs, will be extremely useful. We're looking at the links again. We're unique in Northern Ireland. We have a GP out of ours located beside us, and we're looking at broadening and strengthening our links there. We're also looking at our patients attending with mental health issues. We have got a morning mental health clinic, but we're looking at funding to have someone present there during the day with a dedicated mental health service throughout the day. The Trust has actually funded another middle grade and a further consultant post. It's actually unfunded, but it's as a recognition of the need. We're trying to fill those at the minute. That would give us extended senior evening cover. So it would mean that we would have more senior doctors in the hospital up to 10 o'clock at night. Issues around that, problems around that are concerned really the profile of Causeway Hospital. It's in the news a lot for a lot of the wrong reasons in terms of stability. People aren't sure what the future holds, and that has an obvious knock-on effect on recruitment. So I think it's very important that at some stage a decision is made that Causeway Hospital is going to stay, and then if people look and realise that they might have a stable future career in Causeway Hospital, it may be easier to recruit.
Okay, thank you. Linda, do you want to?
Just a couple of things. Fergal has identified the additional medical staff that the Trust has put in to support the increasing numbers of patients attending Causeway. The same has happened in nursing and administrative staff that work in the emergency department. The other service in the emergency department is the emergency nurse practitioner role that's being expanded to increase the hours of presence of that person. But nursing does remain, emergency nursing does remain a popular specialty for nurses to go into, and we do always have a number of people who are expressing an interest in transferring into emergency care. But looking back over the number of years that I've been involved with emergency care, the nursing staff are moving out of it quicker, and I think the feedback very often is it's a place that's very challenging and very demanding to work in, and to remain working in it for a long time would not be what a lot of individuals would now choose to do. In relation to Fergal has mentioned about the medical staffing recruitment in Causeway being difficult. That's actually a theme that we're seeing for all medical staff in Causeway, not just in the emergency department. Around the future stability of Causeway has had an impact on recruitment of medical staff, and it's around the training is in Belfast, so medical staff are sort of quite centred in Belfast, and to relocate to another geographical area, they obviously want to understand that it will remain for the foreseeable future. And that has made it very difficult. But when staff do come to work in Causeway, the medical population, they actually do express that it's a very cohesive team. Each of the specialties work together and support each other, and they choose to stay. But it's the recruitment of getting them there. So just to say that anything happening in the rest of the hospital impacts on the emergency department, and so that has also had an impact on them.
Okay, my final question, and then I shall pass you over to my colleague Marion. One of the bit disconnections, I suppose, that we've had in gathering evidence is that when we looked at the RQA report in Belfast, one of the issues was a concern about kind of bullying culture within the Belfast Trust. And when we've taken evidence, on the one hand, from senior managers, it's generally been that really that is not a problem, and it's not perceived as being an issue. On the one hand, when we've talked to Royal College of Nursing or Unison or BMA on the other, they've expressed that there is a concern, in some cases suggesting it's endemic across the hospitals, and in others saying, no, it's worse in some places than others. So I suppose my question is, what is your experience in Causeway, and have you any thoughts on why, if you like, the perception, well, we don't know which, frankly, of these are the accurate perception, but why kind of there's such a disconnection between what management's view of what happens and what staff representative organisations' view of what happened. So I wonder if, just from a Causeway point of view, whether you've seen experiences of that or what your experience is, and whether you've any thoughts on why there is such a difference between what we're hearing from kind of staff side and management side.
From a nursing point of view, I'm not aware of a bullying culture. I am aware that it is a very stressful environment, and things sometimes can get said in a manner that would not necessarily be appropriate to either a patient or a colleague. We have channels through staff meetings, through open door. I mean, my door's always open and it never really gets closed. There are other people, there are other managers. My lead nurse is on site all the time. So there's quite a few avenues that people, if they have an issue, can go to. There are some things that are brought up that we can't change at the moment. It's getting the right amount of staff. It's getting things like that, but it's not. I don't feel there's a bullying culture, and certainly not on a downward direction. But I think it's a very strong word. I think it can be misconstrued, and I think it's extremely difficult to prove. But it's a very easy word to say.
Sure.
Certainly, I'm not aware of any bullying of any form in Causeway, in my experience, and I've been there since 2006. And again, I agree with Patricia. I think it's a subjective term. It tends to come across when people are under a lot of pressure and stress, and responses to reactions can be amplified. I'm not saying it doesn't exist, but I'm just saying that when people are working in a particular environment which is challenging and extremely stressful, then requests can come across as unreasonable and be interpreted as bullying, and I can see how that could be the case. I can see you have to, as a consultant, be very, very careful that you don't come across like that, because you have to understand that your medical staff and your nursing staff are working under enormous pressure, and it doesn't take an awful lot to psychologically push them over, particularly during the peak seasons here, during the summer and during the winter crisis, which comes every year. So I think, I'm unaware of it, but I can understand how the environment people work in can lead to that accusation being bandied around.
Okay.
I'd just say finally, we have had absolutely no allegations of bullying made in Causeway Hospital. As Patricia said, we do encourage individuals to express things at staff meetings and various other forums. We also have a whistleblowing policy that is there for individuals to use should they so wish to raise a concern anonymously. And we haven't had anyone adopt the whistleblowing policy. In Causeway, there is also medical trainees have an anonymous reporting system for giving feedback on their placements, as does nursing staff. So there's a number of different routes that staff could use in an anonymous, confidential way.
We get feedback from the General Medical Council and from Northern Ireland Medical and Dental Training Agency on our trainees, and the response has been very good, very positive.
Okay, thank you. Marion now.
Good afternoon. Could I ask two supplementary questions before I go on to ask two questions, one on your emergency department standards and the other on responding to needs of particular client groups? Dr. Dunn, you had mentioned that you're co-located with Dalriada Doctors. Is that right?
Yes.
Could you give us some idea of whether that reduces pressure on A&E or whether it hasn't made any difference, or is that a model that you see?
It's a model that I think has helped reduce pressure. I don't think it's a model that's reduced it as much as it could have. I think the protocols we have are reasonably loose, because general practitioners tend to be rather independent in their practice, and certain individuals are prepared to see patients that others won't. So you're rather, it's the performance of the relationship depends on really who's in the covering general practice that particular evening. I think we can explore it further. We've had a meeting, and we're going to try and broaden their input into the department. We're going to ask them to actually come in and trawl for patients. There was a trial of this in Antrim, and it didn't actually turn out to be particularly successful or cost effective, as I understand. But I think it's something that we will continue to look at and try and expand the role. Ideally, I mean, if the funding was available, we would like to see a GP maybe in the evenings for 4 hours or so, just to try and pick up some of the primary care stuff at times. But how that model would work is unclear, given the experience Antrim had.
Is it a one-way traffic? The GPs refer to A&E, but A&E doesn't refer back?
It's two-way. It's two-way. Yeah. And if we send a patient that we think is appropriate for primary care and they disagree, the patient comes back and there's no quibble. That's the way it works.
My other supplementary question is again to you, Dr. Dunn. In terms of, you'd mentioned difficulties in recruitment and retention of medical staff because of the uncertainty of Causeway's future. Could you tell me how reliant the department is on locum medical staff at the minute?
We're reliant on locum medical staff. I should say recruitment's a problem nationally in emergency medicine. It's not a popular speciality for many reasons. It's a very poor work-life balance, and certainly that's something that's been looked at. We are reliant on locums to provide a service. We have currently six full-time locums,
Out of how many staff?
Out of a total of 15. 15, yeah. The quality is variable. We are lucky in that we have developed what we call brand loyalty. We have a group of locums who keep coming back and working for us. It's a buyer's market. They come and go as they please, really. Although we do have a group of core people who come to work for us on a regular basis that we are of exceptionally good standard, and we're lucky that way. I know other departments don't have that luxury.
Thank you. Now turning to my questions. In terms of the emergency duties standards, you did, the Trust shared those with us and we are impressed by them. And I'm just wondering, could you outline how you ensure that these standards influence practice? And particularly, I mean, I know that some of you have listened to patient experience this morning, and I'm just wondering how you use that as part of your monitoring of these standards implementation.
Okay, do you want to?
Work
to develop them.
The standards were developed by the nurses in the department and probably was based on some complaints where communication was an issue. So a group of staff, both volunteers and conscripts, were taken together, and we worked on those, looking at what staff would like if they were a patient, what they would like to happen, or what not to happen. So we have them printed, and they're up on the wall that patients can see and that staff can refer to. When we initially developed them, we left them for all staff so that they could actually add to them and see if there was anything else that they felt maybe was objective and was would be of help. We monitor those at the minute. We have been working with them for probably just over a year, so we need to actually formally measure them, and we probably will do that with a questionnaire to patients at triage to see is there anything else that we could help. One of the things that did come out was that we weren't maybe answering our phone in a timely manner, and we have kind of redirected some of our admin clerical staff to stay at the nurses' station, and albeit they may not be able to answer the question, at least the phone has been answered and they can get the appropriate person. We also monitor it just from our complaints and from our compliments, which we do get quite a few. But I said it's something that the nurses felt quite strongly about, and also for some nurses it maybe is a direction that you can point them to and say, well, this is actually what is expected. And I said they are visible for patients. Now, I'm not aware if any patients have come and said, well, this is what you have said you will do and you're not providing it. And we also have, some of the standards were that we endeavour, because we are not always able to get patients moved or even seen in what we would class as a timely manner.
Do you want to comment on the standard?
Well, I mean, from a medical point of view, we have monthly governance meetings in the department where we review adverse incidents and any serious adverse incidents, including we have some morbidity and mortality data. And we use that meeting to cascade down to our medical staff any issues that arise. Again, because of our population of locums, it makes the turnover makes communication of some issues more difficult than others.
My final question is responding to the needs of vulnerable groups. Patricia, you've already in your reply mentioned patients with Alzheimer's and children, etc. And you obviously have been conscious of the emergency department journey for them. Can you highlight what are the particular issues that you have highlighted that still need to be addressed to provide a better quality of service for people in those two categories?
We need to be able to speed them through the department in a more timely manner. That can be very difficult at certain times of the day. because we maybe do not have necessarily the staff on board. You could have a particular condition and have either be a child, but your condition is actually fairly minor, and somebody else, an adult, could have a more serious condition, and it's very difficult to get to get everybody to the right place at the right time. I said there are some things that the nurses can do, venflons, taking blood and things like that. It's our speed through the department, and that will always be a problem. Space is one of our biggest problems, in that we're moving patients constantly to get to the right place. If we need to have difficult conversations, if we need to have private conversations with patients and families, we have to move them, because the department was not built for the throughput that we have at the minute, or even for the type of patients. We have curtained areas, and there's no privacy in a curtained area, so you do have to move a patient and their family to a quieter area. So we have a lot more movement to do for our patients. And if you've got a group, somebody that has dementia, you're moving them 2 and 3 places, and you're just confusing them completely. So we do have difficulties, we do have challenges, and certainly with the volume of patients that are coming in the afternoons and the evenings, we have considerable challenges getting them in the right place. One of our other groups, with patients with certain infections that we have to keep isolated, you can't move them, so you do end up with a smaller number of cubicles to work from, and it's getting our patients out of the department. We have no ability, we can move patients and discharge them, send them to the GPs, but we have no control over the patients that are going into the hospital, and that can make our workload 2 and 3 times, because instead of having to get a meal for a group of people for one meal, we may be doing that 3 times in the day. And from personal hygiene point of views and things like that, it makes things difficult. We still, carry out those processes and do the best that we can for the patients, but it is extremely difficult in the small environment that we have.
Okay. Sorry.
Yeah, I was just wondering, Linda, but if you're going to say something directly in that, I can ask my supplementary after that. So, do you want to say?
Yeah, no, I was just going to say an environment that was designed, more than 20 years ago for half the number of patients is very limited. Personal areas like toilets and showers and bathrooms and all of that. So, the staff, while doing remarkably well, I think at times would feel that their ability to provide privacy and dignity to the level that they would wish to do, and that they would wish to see their patients receiving, can be challenged. And when we spoke about Antrim Hospital, because it's a new department, we were able to express some of the advantages of a very recently purposely designed unit. The converse for Causeway is actually true. It becomes their challenges, a design of a department done many years ago.
Thanks, Linda. My supplementary to that was, to what degree have you piloted direct admissions? Rather than everybody coming to the emergency department, to what degree can some patients be immediately, if the GP letter, sent to the ward where they would be better cared for?
I was very interested in one of the patient experiences there. The gentleman said he came up with a letter from his GP and was seen immediately. That would be brilliant if that was true. I would love that to happen. I think there are certain cohorts of patients should go directly towards people who with active cancer or undergoing chemotherapy. Groups like that. I think it's important that they spend as little time as possible in a busy A&E department. Unfortunately, that is not always possible. In fact, it's rarely possible due to the pressures in beds. And they do end up coming to the emergency department. I think sometimes general practitioners create expectations of what's going to happen when they arrive in the emergency department, which aren't particularly realistic, unfortunately. And it's not the way I want it to be, and I would love it to be different. I think there's enormous scope in the future for direct admissions. I think there's a huge group of patients come through the department, particularly the elderly. There's a lot of comorbidities which are difficult to tease out. There's very little I, as an emergency physician, can offer patients like that. They'd be far better admitted straight onto the ward where they can be seen by a specialist in elderly care medicine, as opposed to being seen by me or my staff. Those are just a couple of examples of people I think that's an area that needs explored in the future. I think that direct admissions and a system or a pathway where patients can bypass the emergency department is something that would be very useful, particularly from the patient's point of view.
Thank you very much. Thank you.
Paul.
Thank you so much for your time and counsel and guidance. We really appreciate it. And I was really struck, Fergal, by your very frank remarks. They were hard-hitting remarks, and I really welcome that candour. And there was some real specificity as well, which I found helpful. For instance, your observations, and yours too, Linda, about the quality indicators. So thank you for all that. And I'm conscious of the fantastic dedication of the great majority of health professionals. And I'm also conscious that the current health system structure is, relatively speaking, it's relatively new. It's only sort of 4, 5, 6 years, something like that. And on the one hand, that sounds a long time, but for a large, complex system, that's relatively recent. So the system, I think, I have the impression it's still sort of developing, it's still maturing in some respects. So I'm conscious of those two things. I've got some questions which aren't so much sort of clinical questions, they're more about governance. And maybe they're not strictly sort of directly in your job descriptions, but you're highly qualified, highly experienced, working in the health system. So I'd really appreciate your frank views. I think you said, Fergal, if I caught it correctly, that NHS in England had a lot of financial investment some 10, 12, 14 years ago, and that didn't extend in the same way, in the same degree, to Northern Ireland. And so you said it was therefore unsurprising when some parts of the health system in Northern Ireland didn't deliver as we would all wish. Have I caught it correctly, your point?
Particularly from an emergency medicine point of view, from
Right.
a scheduled care point of view, yes.
Right.
Yeah.
So, if that's right, and I very much respect your view, that's a really terribly profound, sort of structural problem. And I wondered if you could elaborate a bit on it. It might be my colleagues are already completely seized of this matter, but even if they are, could you elaborate a bit on this about the it's a differential you're suggesting, a significant structural differential between NHS England emergency care and and emergency care in Northern Ireland. So I just want to make sure I've understood your point.
I mean, I think what happened was the investment was put in, and then the targets were, right, we're giving you all this money,
Right.
so you have to meet these targets.
Right.
We were just told to meet the targets.
Right. Without the investment.
Without the investment.
Yeah. So could you elaborate a bit on that, please?
Well, I don't have any facts or figures, essentially, but I mean, I know there was a massive consultant expansion in England in the early 2000s. Money was put into the emergency department's training posts. Training posts were created, and a cohort of consultants were appointed. So there's many departments in England have 10 to 16 consultants where I think there's one department in Northern Ireland has a similar number. They have many more junior staff, both middle grade, experienced senior staff and trainees. They have infrastructure in terms of the new, bigger departments. They all have observation wards and ambulatory care areas, and the investment. We actually went to Luton to look at a department there, and they had teams reaching down into the department, pulling out their patients and bringing them to medical admission units. So there was all this enormous structure that was created to speed the patient through, to improve the patient's journey. We didn't get that.
Right.
We didn't get that funding. But the same sort of pressures were put on us as we put.
And the same targets and all that stuff. Okay. I don't know. I don't know if Linda or Patricia, you're not required to, but I don't know if you would do it. Would you like to add to that?
Yeah, the only thing I'd like to add is around the robustness of workforce planning that maybe went on outside of Northern Ireland, and the looking ahead to what the challenges around workforce would be, and putting other alternatives into place to meet some of those workforce challenges, particularly around the medical staff, but also I'm thinking around workforce requirements that non-nursing and medical, so other professions or roles that can actually assist the clinical staff within an emergency department in delivering. And I think that
was stronger in England.
Yes,
than it was here.
I think that looking ahead and identifying the workforce challenges were maybe a little different.
But not just different.
More,
stronger.
More proactive, stronger, more robust.
Patricia, no comment?
No comment.
You see, and it might be I'm just reflecting my ignorance, right? But my mind is open and I want to learn. But I thought there was a higher per capita investment in Northern Ireland in health than in England, actually. Which isn't the same as your point. Your point is slightly different, but that's why I'm really interested in this, because maybe there is now a higher per capita investment. But you're suggesting that sort of historically there's a structural imbalance which hasn't been addressed.
I don't know the exact ins and outs of it in terms of block grants and things, but I know the investment it simply didn't happen in the same way here.
Okay. Thanks. Just turning to something else, and again, it's a governance issue. But still, I'd really very much appreciate your views. And I'm just looking at this. It's the framework document of the Department of Health, Social Services and Public Safety. The framework document, an important document, and there's one passage. It's just 2 or 3 sentences. I'm going to read it if I may, but you're probably familiar with it. It's under the heading of Personal and Public Involvement, paragraph 5.1, and it says this: patients, clients, carers and communities must be put at the centre of decision making. This means that they must be properly involved in planning, delivery and evaluation of their services. HSC bodies are accountable to people and communities for quality, accessibility, responsiveness of the services they plan and provide. Really rather dramatic paragraph, actually, the 5.1 paragraph, which you probably are familiar with. And I suppose I'm interested whether or not, and you have commented, some of you have commented on this already, but I'd be interested to know whether or not you think that present governance arrangements are sufficient to deliver that, to deliver 5.1. 5.1 says the services must be the public, patients, clients, carers must be properly involved in planning, delivery and evaluation of services. And the health system, of course, provides a public service, so what 5.1 is saying, I think, is that if it's a public service, then there should be public participation. And I would just say that it seems to me that one reason why public participation is terribly important is that it enables the public to better understand the constraints. So otherwise there are misunderstandings. So with good public participation, then that enables health management to convey the complexities, the limitations of budget, the choices that have to be made. So it can actually help, it seems to me, management. So to go back to my point, do you think that presently in this still developing system, the still maturing system, do you think that there are the right mechanisms in place yet to ensure that patients, clients, carers and communities are properly involved in planning, delivery and evaluation? And while you think of that question, think about that question, I am conscious of some of the participatory mechanisms which we've talked about and you've alluded to this afternoon. The PHA has some sort of participatory responsibilities, and the PCC and 10,000 Voices and patient reference groups, I think they're called, and so on. So I appreciate there are some participatory mechanisms, but I just would really welcome your frank view as to whether or not you think these mechanisms have matured so that there is this proper involvement of patients, clients, carers and communities in planning, delivery and evaluation. What advice do you have for me about that, please?
See if there's something to comment.
I think there's nothing to be scared from openness. I think people will understand why there's limitations to the service if it's explained to them why. I think there's a pressure, of sometimes politically, to deliver on promises, which put pressure on the service. And then, but I think if why that is not possible, why that delivery is not possible was explained, I think people would understand and accept that. I think people can't have.
So I think we're on the same page in terms of the value of public participation. But as frankly as possible, do you think that there are yet in place in this relatively new system? Do you think there are yet the appropriate public participatory mechanisms that are reflective of 5.1? What do you think? Or before Linda. But you can say pass, or call a friend, or whatever.
I think, I mean, there is the non-executive board in the trust. I think they have a big role there, which I don't think has been fully exploited.
Yeah. See, that's a really good point, and I should have included them in my little list. But the impression I'm getting, but I repeat, my mind is open. The impression I'm getting that those non-executive board members are really important. They're really important. I'm not knocking them at all. But they're sort of there as professionals doing a terribly important service. And the impression I'm getting is that they're not sort of bridges to the community.
No.
So they are important, don't misunderstand me, but they're not quite what I'm getting at.
From a very grassroots level, the patients that are coming to our department have absolutely, I'm not saying no idea what to expect. They know that there should be an outcome. It will either you will give me treatment or I will be admitted. But they don't understand the processes, they don't understand the constraints, and nobody has actually ever told them. If somebody can't get a GP appointment, they will come to the emergency department, and it doesn't make any difference what title you give it, whether it's accident emergency, people will seek out care wherever they can get it, and that's part of the problem. They just don't always know where it is that they should be going. That's why I don't think from a personal point of view, we are talking to the general public enough about the service that can be provided, because we will never ever have an all singing, all dancing service. There will always be constraints. There will always be money constraints.
So that point of yours, Patricia, is a really important one. It's about information. It's about communication. And I think one of the dominant themes we've heard for the last days is about the critical importance of communication. And communication and participation are really close, but they're not quite the same thing, because you can pass information down to the public without their participation, right? So there's a real need for health information to get to patients and carers and communities and families. I'm trying to get at something a bit different. It's including them in well, as 5.1 it's 5.1 says it brilliantly, actually. I mean, I couldn't have put it as elegantly myself. This means the patients, carers, clients, blah, 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 communities must be properly involved in planning, delivery, evaluation. So that's a bit different from information, right? So I'm just trying to get a sense of, from your professional experience and all your years of experience, whether or not we've quite yet got the systems in place.
We haven't. They
No.
haven't been included. The general public haven't been included.
But what about the PCC? Because, I mean, when you look at the statute of the PCC, it's really wonderful. So, one of their responsibilities to do this, but it's not quite enough.
It's not. I mean, it just doesn't seem to be hitting, I said, at grassroots level so much.
Can I just
Thank you for your patience, Linda. Thank you.
I think we've invested a lot of resources and energy into retrospective views of our service. So we have lots of systems around complaints or giving compliments, looking back when things go wrong, how we do that. What we haven't invested enough in is the looking forward and engaging with our community in how we develop services into the future. So I do think that all the organisations and including those that deliver care in the trust absolutely have good systems and mechanisms in this very junior health service that we're working in, and you're quite right, it is still very young. 5 years is not a long time. I think where we need to move forward is actually how we begin to engage and have our community residents involved in how we take services forward in the future, and that's where I think we haven't really cracked it yet.
So, do you have any suggestions on sensible, practical, reasonable, next steps? Because it's a journey, right? It's not going to suddenly happen. No. So what are next practical, sensible, reasonable next steps in order to deepen and enhance and open up more public participation in the way anticipated by 5.1? What could be done?
I think there is lots of groups out there that represent different elements of the community, whether it's people with certain conditions or certain geographical locations. But it is how we communicate with them, how we link them into some of the pieces of work we're doing, and inviting them to be part of the planning groups for those. Why wouldn't we have by going out to outreach to them? We could meet with any group in any community centre and any venue where people gather, and there's lots of them. We could take those opportunities and go and ask what services people want of the future, and that's where we can actually start having the dialogue around the difficulties and constraints, because we won't be able to provide everything for everybody, but what we want to do is provide absolutely the best we can with the resources we've got. And I think the more that our community do that in partnership with us, then the more we've designed a service around what they need. I'm a member of community of somewhere, and that's what I would like. I would like somebody to ask me what I would like in the future, and if that's what I would like, well, why is that not what we should be offering to all our community citizens, whatever their local or regional hospital might be.
So, Linda, I don't expect you to have a magic answer, because there isn't a magic answer, but just off the cuff, I wondered if you could just respond to this idea, and it might be a crackpot idea, but I think presently boards have 6 non-executive directors.
Yes.
And at the moment they're largely very pillars of society, professional types, most of them. But what about if, say, 3 of them fulfilled that function, and then 3 of them were given a different responsibility, which was to do what you've just described? Now, I don't know how it would work. Really, I'm being very frank with you. But to reach out to the community, so to go and make themselves available to the community, but not just make themselves available, but to reach out to the community and talk with the community and then report back to the board. What about that?
Oh, absolutely. I think that we should have individuals on all our trust board who are actually representing the community and have links in and are feeding back and are going back out from the trust board. Absolutely, I think we should explore. If the principle is right and the principle is agreed and accepted, then the detail can be worked through after that.
And I'll shut up shortly. But just on the same sort of theme, again in this document, the framework document, there's a piece about local commissioning and the LCGs, the local commissioning groups, and I'm really struck by it, because again I know it's tedious to read out lots, but may I just bear with me if you don't mind, because it says in this important document, it says LCGs have a lead role in the strategic commissioning process, in particular having helped to shape strategic thinking to apply it locally on behalf of their populations. And then I'm missing lots out. LCGs identified local priorities, taking account of the views of patients, clients, carers, wider communities and service providers. So the LCGs are sort of important in terms of public participation. Do you think that they're fulfilling that role yet? Have they reached that level of public engagement?
I mean, in terms of commissioning groups, we have had some in our emergency department. We've had some brief discussions with commissioning groups about creating pathways for patients to shorten the patient journey in and out of the emergency department. How they've come about deciding that's the service they want to commission, I do not know.
Yeah, because that point of yours is really good. That shows they're speaking to you, which is brilliant. I'm sort of interested to know whether they're speaking to the community.
Yes,
do any of you know if they are really?
I do think that there is different levels of communication from the LCGs, because we meet with the LCG in terms of developing a commissioning plan for our service, and they would indicate of some communication, that they've had with the community and different community groups that they would liaise with. So I do believe that there is some degree of that going on, but I would level the same consideration to them as I would with ourselves. The trust, there's always more that can be done. It can always be done better. And our local commissioning groups are young organisations as well. And I think that we look at all the disease profiles and put in a service. So we make a lot of decisions on our community's behalf. Whereas I think that if they were were making those decisions with us, we would have a much more responsive service.
It's not easy to do, but
No.
okay, that's terribly interesting. Thank you. And lastly, and very briefly, and this isn't a test, but it'll help me. Do you know who your Equality and Human Rights officer is in
Yes.
in your trust?
Yes, yes, and she's
She's in the audience.
Yeah, I know she's in the audience. But
she's here. Patricia, do you?
Oh,
do you
yes.
know?
Okay. Okay. So Fergal, no, but the others, yes. Okay.
Okay.
Okay. Thank you very much for your help.
That's great. Do you want to make any last comments, or in terms of before I wrap up this particular evidence giving? Anything you want to say or feel you haven't had a chance to say, or anything you think we've missed that you'd just like to comment on? Okay, that was quite a long evidence session by our standards, but really very useful. As we've said to everybody who's given evidence, if you want to augment anything or you think we've missed anything, we're happy to take any further written material that you'd like to provide us. That will be very useful. And I know how busy lives all three of you, I'm pretty sure, are leading, so thank you very much for giving up your time this afternoon. That's been really helpful to us, so thank you. Thanks a lot.